Great. Thank you, Anna, for the nice introduction. And thank you as well to TB Vets for having me. It's a great honor to be speaking to you all today. And we're also very grateful for the support that we've received and continue to receive from TB Vets. It really does make a difference to what we're able to do for patients. So thank you very much. So I was asked to speak today about COVID in the lungs, potential short-term and long-term complications. A few disclosures that I have that I put at the beginning of each talk. None of these are really relevant to this topic, however. I was asked to cover three main topics today. The first is how do the lungs function? And I'm going to do that relatively simply, but in a way that I think will drive home a couple of key messages. We'll talk about what tests do we use to diagnose and monitor various lung diseases. And again, this will be a relatively high-level overview. And then we'll finish off by talking about how COVID-19 affects the lungs in both the short and the long term. And we'll stop at the end for a lot of questions as well. So first, how do the lungs function? So again, a very high level overview. So this is a schematic of the lung. So we have airways, as you see down here. There are blood vessels that run along the arteries in the red, the veins in the blue. Those get smaller and smaller as they branch out, and as the airways branch out and get smaller and smaller until you get to these air sacs, the alveoli, that look like bunches of grapes at the end of a stem. And the alveoli is really where the business of the lung takes place. Once air flows in here, oxygen gets absorbed through the alveoli into the bloodstream. And then air gets pumped back out that's more full of carbon dioxide after taking out the oxygen. So that's how things look in a schematic. To simplify this a little bit further, this is my own PowerPoint skills showing essentially an airway that leads to an alveolus. There would be a whole group of alveoli. And then there's a capillary, which is a very, very small and thin-walled blood vessel. And oxygen is able to come in as part of the air that we all breathe in. 21% of it is oxygen. It goes through this very, very thin layer and then gets absorbed into the blood, bound to hemoglobin, carried away to do its business elsewhere in the body. That's how the lungs normally work. This is called the interstitium, which is this very thin layer right here. This is what a lung would look like on biopsy. So this is the end of an airway, and then all these little things, they're cut in cross section, but they're all kind of continuous with each other, and these are all the different little air sacs. So in a normal human being, this would all be filled with air. Air would be flowing in and out, and then so small that you can barely even see them. In some of these corners would be these really tiny blood vessels where hemoglobin or red blood cells would be passing through and picking up oxygen and dropping off carbon dioxide. This is what airway disease looks like if you were to do a biopsy of somebody who has chronic or acute on chronic airway disease. And you can see there's a lot more cells. Everything here that's essentially purple is a cell. There's a lot more gunk in some of these airways. And you can imagine that this is going to cause a lot of problems. So if we go back to our simple schematic of the normal lung over on the left and then airway disease on the right, these would be things like asthma or COPD, chronic obstructive pulmonary disease, or emphysema or cystic fibrosis. These cause a couple different problems to this whole process. First thing is that when air is trying to get into the body, there's some thickening in the walls of the small airways, and this just makes this a little bit narrower and a little bit harder for air to pass through. When we listen to people, you can hear this turbulent air as a wheeze when you listen with the stethoscope to their back. And this makes it feel like you can't get a good breath in. And actually even more obvious often is that you can't get a good breath out. So you can't exhale air through this narrow opening as well as you could before. The second thing that happens in airways disease is that you often get a bunch of mucus. That's what's in green here. And this mucus makes it a thicker transition path that oxygen has to take to get absorbed into the capillaries, and also further decreases the diameter of these small airways, making it harder for air to flow. And these are the two main consequences that we see with airways disease, is that you have these thickened airway walls and you have gunk in the alveoli and those small airways that impedes oxygen diffusion into the body. This is a few examples of fibrosis or pulmonary fibrosis. So this is another main type of lung disease. This is what I focus in a little bit more. And these, again, are all different biopsies from patients who have interstitial lung disease, or pulmonary fibrosis would be the other term that we use. And you can see a whole bunch of scar tissue here, this pinkish stuff. Pink is not good. Pink represents scar. And you can see it in different places, relatively thick here, or really just kind of a lace-like thickening all over the place in this one on the right. And the same kind of concept applies here, but instead of problems in the airways and the alveoli, we actually have a thickened interstitium. That's why it's called interstitial lung disease. So when this interstitium gets thick, it's harder for oxygen to diffuse across that layer into the body, and you don't absorb oxygen quite as well. So these are two of the kind of hallmark lung diseases that we deal with, and really captures the biology or the physiology of many of the other subtypes that we deal with as well. So what tests do we use for lung disease? And there's a whole bunch of different ones, and I've broken these up into ones that are used more so in monitoring and some that are used more in the diagnosis of the disease. So if we start at the top, these also go generally in terms of least invasive to most invasive. So there are some symptoms that we assess, and we'll go over each of these in a slide in a second. Pulmonary function tests, various walk tests or measurements of functional capacity or exercise ability. There are a couple different types of chest imaging tests that we use, some blood tests, some tests that we can run on sputum that people cough up, bronchoscopy, which we'll come to in a sec, and then lung biopsy. And again, the ones at the top are used more in monitoring, the blue and the purple ones, and then the purple and the red ones are used more in the initial diagnosis and generally not repeated over time in a given patient. So for symptoms, there are three main ones that we focus on. There are others as well, but dyspnea, which is the medical term for shortness of breath or an abnormal sensation of breathing that's uncomfortable. Cough is common as well, of course. Cough can be productive or non-productive. Sometimes we also ask about wheeze. Well, we do ask about wheeze, but sometimes people have wheeze, which is more common in airways disease. And then the real symptom that people struggle with often is functional limitation or exercise limitation. Inability to either hike up hills or walk on flat ground, or even walking across the room can sometimes become a problem. So these are the things that patients volunteer to us or that we solicit by a history. Pulmonary function tests are one of the most useful tests that we do to quantify the severity of a disease and to follow patients over time. This is the printout of a PFT or a pulmonary function test showing the three main components. I'm going to go into each of these in a sec. All of these components, the spirometry, plethysmography, and diffusion, these three main components, well, the first two components anyway, come mostly from these two curves. So these are a printout essentially of how much air patients can exhale over time and how well air is flowing out of the lung during different parts of the procedure. So if we start with spirometry at the top, spirometry is basically a measure of airflow. So how well air is flowing into the lungs or out of the lungs. And there are a couple main ones that I'll focus on for a sec. So the FVC, or the forced vital capacity, is a measure of how much air you can move in and out of the lung in one big breath. So that's your forced vital capacity, how much air you can move in and out of the lung in one big breath. This person's forced vital capacity is 74% of normal, and that would be considered a little bit below the lower limit of normal. So this person has a mild reduction in how much air they can move in and out of their lung in one big breath. The FEV1 is a measure of how much of that volume of air they move out in the first second. So if you imagine, take a deep breath in, blow out as hard as you possibly can, as fast as you possibly can. This FEV1 is the forced expiratory volume in 1 second. And that gives us a good understanding of whether the patient has airflow limitation or narrowing of those small airways that I showed before. So this FEV1 would be the most useful test, along with this FEV1 to FC ratio of how much airways disease a patient might have. So we would see these kinds of numbers go down in patients who have airway disease. I'll mention as well, we also repeat this test after giving patients a bronchodilator, something like Ventolin, which is that little blue canister that you sometimes see people taking in movies and so on. They usually do it wrong if you're looking at a movie, but that's the inhaler that they're usually using when they're struggling for breath. We give patients usually 4 puffs of that inhaler to see if any of the abnormalities get better after using that inhaler. And that's a test that we use mostly focused on asthma. The next part of the test is called plethysmography, which is a bit of a mouthful. And basically, this is measuring different lung volumes, that the different volumes of air that the lungs can hold. The main one that I would focus on is this total lung capacity, which is the overall volume of air that you can keep in your lungs after taking as deep a breath in as you possibly can. This person is within the normal limits at 86% of normal. And then these other tests are different volumes depending on the different parts of the breath cycle. And I won't go into the details of those other components. The last test, diffusion. So this is a measure of how well oxygen gets absorbed into the body. And we give people a very tiny amount of CO, or carbon monoxide, not enough to cause any kind of harm whatsoever. And we see how quickly carbon monoxide gets absorbed into the body. And we do that just because it's a molecule that you're not encountering in daily living. So it's one that we can standardize and test the absorption relative to population norms. And again, this patient has a slight reduction in their DLCO, meaning that they don't absorb oxygen quite as well as they should. Putting this all together, this is a patient who has a very mild form of pulmonary fibrosis in the end. So those are the pulmonary function tests that we measure. These are all done in a formal pulmonary function laboratory, which is almost always based in a hospital. And these are one of these things where you sit in this glass box and you do a whole bunch of breathing maneuvers. It takes about 45 minutes or an hour to do these tests. So they're done pretty rigorously and not easy to do. The next test I'll mention is the 6-minute walk test. So literally it is what it sounds like. You walk for 6 minutes. We keep an eye on what your oxygen saturation does, and we measure how far you can walk. And you're supposed to have a track of at least 30 meters long. So it has to be a fairly long hallway that you're doing this in. And again, we have population norms. So what the values would expected to be for patients of a given age and a given height, and for men versus women. And these are a good way of checking how a patient functions in their day-to-day living. If your walk distance is less than 150 meters or so in 6 minutes, then that suggests to us that you're having a hard time doing some of the things that we would expect people to hopefully be able to do without their lung disease, things like doing groceries and walking to a bus stop and things like that. Chest imaging is really important as well. Probably beside pulmonary function tests, these are the tests that we do most often. I've got an X-ray on the left. So this is just a plain frontal radiograph. These are the kinds of X-rays that have been around for over 100 years now, where basically you take a picture head-on of a patient. So this is the patient's right lung. This is the left lung. This kind of triangle thing here in the middle is their heart. And you can see the diaphragm here, as well as the abdominal contents below this. This patient has some abnormalities on this X-ray. There's a little bit too much white here compared to normal. White in the lungs generally is not good because white represents more tissue or more density than you should have. The lungs should be filled with air, which would be black. This is a CT scan from the same patient. CT scans are a fancier kind of imaging that's been around for, not sure, 40 or 50 years now. And this is the one where you lie down on a little stretcher that zips into a tube or into a donut and then out of the donut. And it takes images of you in cross section. So kind of like you're cut up like a loaf of bread, and we're looking at the insides of each bread slice. So again, patients' feet are coming out towards you from the screen. So this would be the right lung, this would be the left lung, this is the aorta looping over, and you can see the spine here, and then ribs and cross-section around the outside. And again, lungs should be mostly black with these little white branches of blood vessels that run through them. And there should be this crisp black-white interface around the outside of the lung. And instead, we see a little bit of this kind of ratty white stuff around the outsides of these lungs, and those are little bits of scar tissue as well. So this patient has a form of pulmonary fibrosis that matches up with the pulmonary function test that I just showed. CT scans have a little bit of radiation. They're not a ton. So we don't repeat them every visit, but we do repeat these every 1 to 2 years for patients with pulmonary fibrosis, and sometimes similar frequency or sometimes a little less often in other diseases as well. X-rays are sometimes helpful as a screening tool in patients who have more acute presentations, but they don't really show as much of the lung as we need to see for a lot of what we deal with these days. There are a whole bunch of different blood tests that we look at as well. Depends on the patients and which ones we are looking at, but there are some blood tests for autoimmune conditions that frequently affect the lungs, tests of inflammation, tests of infection. We can also look for cardiac disease, which is a frequent thing that we see along with lung disease. And then there are some genetic disorders like cystic fibrosis and alpha-1 antitrypsin deficiency and others. These are just a smattering of some of the ones that we consider. It really depends on the clinical scenario as to which of these we pursue, or whether there are some other uncommon ones as well that we'll often do. This slide could literally include hundreds of different things on it. Sputum tests are more helpful in acute situations for the most part, looking for acute infections. So things like bacterial pneumonia, sometimes viral pneumonia as well, where we'll either test the sputum or a nasal swab. And I'm sure most people on the call have probably had a COVID swab at this point. That would be an analogous comparison to this. Sometimes we can also look at types of inflammation based on what cells are in that sputum. It's not done as often, but sometimes is useful in asthma. These ones become a little bit more invasive. So bronchoscopy, so bronch basically means airway. Oscopy or scope means taking a look. So bronchoscopy is a camera or a scope that we put down through either the nose in this case, but more often the mouth now. We go down into the airways and you can see this bronchoscope. This has a bendy part that you can control. It's kind of like a video game for respirologists, where you can navigate out and do fancy things with this camera. You can either look at stuff just by simple inspection. You can take washes where you suck some stuff out and see what cells or what bacteria or what viruses are in that stuff that you wash out. We can do brushes, which are basically like putting a little pipe cleaner down into the airways and taking out cells that way by stirring stuff up. And then we can do biopsies as well. And those can help distinguish between infections, different types of inflammation, cancers, other things as well. Sometimes we can also use bronchoscopy to treat patients. So depending on the type of cancer, sometimes we can cut out much of that cancer to open up the airways. Sometimes we can take out a peanut that you might have had go down the wrong tube. A whole bunch of different things like that specialists are able to do with the bronchoscope. Nowadays, this is an old picture. Nowadays, there's a huge setup that we have in the bronch suites with equipment that has big screen TVs. You can have imaging that's in real time, so you can see exactly where you're going. You can map yourself to an abnormality that you saw on a CT scan by having a 3D real-time rendering of the patient and where your scope exists in relation to that abnormality that you might have seen on a previous CT scan. So a few different fancy tools like that. We actually also have slightly larger scopes now that have an ultrasound on the end of them, so we can make sure that we're getting a biopsy of that thing that's behind the airway that we otherwise wouldn't be able to see if we didn't have an ultrasound that could see what was hidden back there. So bronchoscopy has really advanced a lot in the last 10 years. It's advanced quite a bit. More invasive than bronchoscopy. Sorry, I should mention bronchoscopy, it's a day procedure. We do several of them a day, so it's a pretty minor thing as far as we're concerned. For a patient, obviously, it's a bigger experience, but from a physician perspective, it's something that we do quite frequently. Lung biopsy is becoming less and less common as bronchoscopy and CT scans have gotten better and better. So lung biopsies are another way, usually a more invasive way of getting tissue. So I've mentioned bronchoscopic biopsy on the previous slide. We can also do what's called a transthoracic needle biopsy, where we put a needle through the patient's skin, and we see this spot here that shouldn't be there. Could be cancer, could be a weird infection, could be some focus of inflammation. And we can see on the CT scan that we're putting the needle into the exact right place. That's exactly what we want to do. We don't want a needle over here. We want it to go right down the middle of this, so we're getting out the right sample. So that's a transthoracic needle biopsy. More invasive than that is a lung biopsy. So there are two ways of doing this. It used to be that these were done through an open thoracotomy. Open meaning you're opening up the patient through this big incision. You're actually able to see the lung directly with your own eyes, and you take out a little piece of whatever the problem was. And this really shouldn't be done anymore outside of things like lung transplants or maybe a pneumonectomy where you're taking out the entire lung. Nowadays, if we're doing a lung biopsy, we're using these keyhole incisions, what's called a video-assisted thoracoscopic biopsy, or a VATS biopsy, where it's really just 3 incisions that are each about a centimeter and a half long. And it's some places actually even do this as a day procedure, but most of the places will admit a patient for 2 or 3 days afterwards. These still have some risk involved, so we generally try to do a bronchoscopic or a transthoracic needle biopsy whenever we're able to. And then open thoracotomy really shouldn't be done anymore for lung biopsy purposes. So those are the types of tests that we do to diagnose and monitor patients with lung disease. The last part of my talk, which is a little bit more complex, is how does COVID affect the lungs? And we'll talk about some of the tests that I've mentioned in the previous sections as we go through this. So the way I think of COVID, after having seen a whole bunch of patients in the acute and in a chronic setting, is really that there are quite variable presentations, especially in the acute situation. So in the acute situation, I'm sorry for the acronyms, I'll try to read these out, but in the acute situation, there are a lot of different things that can happen. About half of patients, and maybe even more now with vaccines and with Omicron, about half of patients seemed to be asymptomatic, so they lacked any symptoms whatsoever. And kind of working from the head to the toes, there are some neurologic consequences like stroke, encephalopathy, which basically just means some inflammation of the brain. People can also have some anxiety, probably along the lines of post-traumatic stress disorder, where you can imagine, especially in wave 1, being admitted to hospital, where you're getting cared for by a person in a spacesuit, essentially. That can provoke a lot of anxiety in people, and that's maybe the most important long-term sequelae of COVID is some of that anxiety that comes after the fact. Anosmia and ageusia is lack of smell, lack of taste, or loss of smell and loss of taste, and that's made it into the news frequently as a common feature of COVID in the short and in the long term. Upper respiratory tract infections, this is just a runny nose that people would often get, a sore throat. That's what COVID did to me, fortunately. Heart attack, so myocardial infarction, pericarditis, arrhythmia. So the heart can definitely be involved. Some people can get an acute kidney injury, inflammation of the liver, hepatitis, diarrhea, and ischemic colitis, where the bowel loses part of its blood supply, and that's a big problem. And then deep vein thrombosis or blood clots, and that is, I think, something that most people will have heard about with COVID as well. In terms of the pulmonary complications, the most common thing that we see is pneumonia. And pneumonia can come in a couple different forms. It can either be the virus itself causing that infection, but the virus itself also weakens people's lungs and their immune systems in the acute situation that predisposes them to a secondary bacterial infection. So when people get fairly sick with COVID, sometimes they'll start to get a little bit better, and then they'll get worse and feel like they got hit by a truck. That hit by the truck phenomenon is probably a secondary bacterial infection. So when people who have persistent symptoms, we'll often just treat them on spec with antibiotics to cover those bacteria. People can also have pulmonary embolism, which is essentially when this blood clot in the leg breaks off, goes up into the lungs, gets lodged in the lungs, and causes people's oxygen levels to drop acutely. And this is probably the second most common complication in the lungs. Very rarely, patients can have a collapsed lung, what we would call a pneumothorax, or a PTX for short. And then in some patients who get really sick and go into the ICU, they have what's called ARDS, or acute respiratory distress syndrome. And that's where people are on the ventilator and really not doing well for usually a period of time. In the longer term, it's a little bit simpler. Many of these acute things go away, but there's a lot of, as I mentioned, post-traumatic stress disorder and depression that lingers in many patients. There are some people who have persistent neurologic deficits. Some people that can have permanent cardiac injury and chronic kidney disease and loss of protein in the urine. and then weak muscles, which often will recover over time. From a lung perspective, the two main sequelae of COVID in the long term are pulmonary fibrosis and pulmonary hypertension. And I would say that the pulmonary fibrosis is much more important and prevalent in the longer term. And I'll show you some data on that in a few slides. So I'm sure everybody knows that COVID-19 is a coronavirus, which is a family of viruses. Some of the most common causes of the common cold are actually coronaviruses, but the ones that are most closely linked to COVID-19 in the past were SARS and MERS. And I'm sure SARS is familiar to people from what was it, almost 20 years ago now, and MERS as well over the last couple of decades has been in the media intermittently. So what lessons can we learn from SARS and MERS about what's going to happen to COVID-19? So this is a timeline of the SARS outbreak. This is one of the first publications comparing these two pandemics. So the SARS outbreak that happened in 2002 to 2003 lasted literally for less than a year. And I'll show you in a sec how many patients ended up getting SARS, but it was a whole lot less than what we've got with COVID. We probably surpassed the impact of SARS by mid-January, if not even earlier in 2020. So COVID-19 was quite a bit different from SARS right from the get-go. SARS ended up having about 8,000 to 9,000 patients ended up having SARS back in 2002, 2003. And the mortality was quite a bit higher for SARS than for COVID. And this was one of the reasons that people were panicked about COVID at the beginning, was because we were concerned about this very, very high mortality rate, which really would have changed the world much more dramatically even than COVID did, which is maybe hard to believe. SARS happened in Canada, mostly Toronto and Vancouver. Vancouver, we were fortunate. There were a couple of very astute physicians who recognized it very early and squashed the outbreak almost before it began in Vancouver. Toronto had more cases. And then the most cases came from China and Hong Kong at that time, with a few in Taiwan. The difference about SARS is that SARS was not infectious before you had really severe symptoms. So SARS, you only became infectious after you had severe symptoms. And so you had the ability to isolate people before they transmitted the virus to other people. And I think the same could be said for MERS as well. MERS is even more frightening than SARS, has a 34% mortality of the 2,500 cases that have been identified, mostly in the Middle East, with some as well in South Korea. So MERS and SARS are both quite scary, but fortunately not as infectious as COVID. But what happens to SARS and MERS? So not as infectious, but if you do get it, what happens in the long term? And this is a systematic review, which means that they pulled together a whole bunch of different studies that had been published before and synthesized them all in a nice, neat package. And this shows the number of patients who had abnormalities in their breathing tests. Big breath. And at 12 months, you had between 5 and 32% of patients who had persistent abnormalities in their breathing test. And 1 year after the fact, that's probably where you're going to stay. And you might actually even get worse over time if there's some ongoing scar tissue that self-propagates over the longer term. If you look at the DLCO, somewhere between 5 and 34% of patients at 12 months had abnormalities in the DLCO. And again, this is a measure of how well oxygen gets into the body. If you looked at 6 months, which most of the studies had 6-month measurements, it was even higher than this in some of these other studies. So there might be a little bit of a bias here. So pretty common for people to have persistent abnormalities long-term after SARS and MERS if they survived the initial infection. This is a spiderweb plot looking at different impacts of SARS and MERS on quality of life compared to normal subjects and normal subjects who have a chronic underlying disease. So the way this works is the closer you are to the outside, the closer you are to perfect health. So you want to have your ratings of quality of life as far to the outside as possible and as far from the middle as possible. If you're in the very, very middle, essentially I guess you're dead if you're right on the very, very middle, or you'd rather wish you were dead. And the people on the inner rings of this have more significant abnormalities in these different components of quality of life. So pain, vitality, their mental health, and so on. And essentially, the take-home message here is that your quality of life is pretty good if you're normal, as expected. If you have a chronic disease, it's worse. But even more impressively, if you had recovered from COVID, or this was SARS and MERS at this point, if you'd recovered from SARS and MERS, your quality of life was actually worse than if you'd had an underlying chronic disease. That just shows you the impact of these acute illnesses on patients. It actually is more impactful to have this acute illness than it was to have an underlying chronic disease. There are a number of other studies that have looked at SARS and MERS. So a 1-month follow-up showed that almost everybody had an abnormal CT scan after having SARS. 62% of those had some evidence of scar tissue or fibrosis. Generally, those people were older and had more severe acute disease. And there really wasn't very much long-term data about the imaging abnormalities. These are just a couple examples. This is a 31-year-old man. He had pretty bad pneumonia, as you can see here and here in the acute setting. 6 months later, he still had a whole bunch of extra whitish kind of splotches and whitish dots here. And at 7 years after his infection, he still has all of these whitish dots. So he never really recovered from an imaging perspective. Same thing for this 30-year-old woman. 3 months later, she had all this haziness around here, little splotches of haziness here and here as well. These improved, but not completely at 9 months. And even at 7 years, she still had some abnormalities on her chest CT scan. And this just shows that the lungs do continue to improve up to about a year or so after SARS or MERS, but you are left with persistent and chronic abnormalities. If they looked at patients at 7 years, 80% of their patients had abnormal pulmonary function tests 7 years after their acute infection. So now to COVID-19. So I'm going to start with a few case examples just to provide a bit of illustration. So these are three of the first people that I saw in clinic after their initial infection. So first patient was a 57-year-old male. He'd never smoked before. He had dyslipidemia, so he had high cholesterol. And he presented initially with a sore throat, headache, fevers and sweats, fatigue, exertional dyspnea or shortness of breath. And he was admitted to hospital for 3 days. He was put on a little bit of oxygen, 2 liters by nasal prongs, which is not very much. His saturation was a little bit on the low side with that. If you measure your saturation, it should be above 95. He had a pretty good marker of inflammation. His CRP was 112, so his body was pretty inflamed. And when I saw him at 3 months, he had minimal fatigue at that point. He'd recovered pretty well, and he was now back to doing 40 push-ups a day. Before he was doing 60. So he was in pretty good shape beforehand, no matter how old he is, especially for a 57-year-old. This was his x-ray, and he had a lot of inflammation, and I guess you'd call this pneumonia, so acute COVID pneumonia, with more whitish stuff on this x-ray than you should see. Second patient was a 70-year-old male, never smoker, had high blood pressure, hypertension, and again, high cholesterol. Similar presentation initially, but he was admitted for 5 weeks and was intubated, put on a ventilator for 22 days. He was pretty well prior to his admission, so he just had really minor comorbidities. These are things that if you're a 70-year-old and this is all you've got, you're in pretty good shape compared to many other 70-year-olds. And this was his x-ray at the presentation when he was admitted to hospital, and you can see his left lung has a lot of inflammation in it, a lot of infection. His right lung looks a little bit better. And if with a bit of a close eye, you can see this is when he was with a breathing tube down his throat. So he was quite unwell at this time. And he unfortunately had been wheelchair bound since discharge. He was so weak that he was still starting to recover 3 months after the fact. He was still limited to a wheelchair despite being in pretty good shape before that. Third patient I'll show is a 70-year-old woman, a never smoker, had diabetes, which we knew was a risk factor for more severe COVID, also had high cholesterol, presented with fatigue, fever, and headache, and she was admitted for 10 days. And similarly to our first guy, she was on a little bit of oxygen, saturations that were pretty normal, but maybe a little bit low for giving a bit of oxygen, and had a lot of inflammation in her body as well. And you can see that her chest x-ray, again, there was a lot of inflammation on this x-ray. At 3 months, she felt back to her baseline, but she hadn't really got back to doing the exercise that she had been doing before. And she was, again, a quite fit 70-year-old woman. So this is their story up to 3 months. And then this is what their CT scans looked at 3 months. And all three have abnormalities. There's some more patchy whitish stuff or light gray stuff than this guy, more confluent kind of patchy stuff here and lines of scar tissue in this guy. And then this person down at the bottom had more lines of scar tissue down here as well. And if we look at their lung function at 3 months, this is what their DLCO was. And DLCO, again, is a measure of how well your lungs are absorbing oxygen. So it's a good global measure of your lung function. And these people all had abnormalities in their DLCO, ranging from 77 down to 43% of normal. So this woman at the bottom was functioning essentially on 43% of what her lungs should have been giving her. So that's at 3 months. The questions that all these people asked when we were seeing them naturally is this going to get better and is this going to progress in the future? And we had no idea at that point what was going to happen. Fortunately, most people had some improvement over time. So this is showing their values at 6 months. So all three had an improvement. I didn't cherry pick these out because they all improved. I actually picked these slides out before we even saw what happened at 6 months. But they all did improve on the order of 5 to 15% or so, which is a pretty substantial improvement. Although you can see that these bottom two patients are still not near the normal level of 80% is what would be considered relatively normal. So they improved, but not back to normal. So there was definitely a significant loss of their lung function caused by this one episode of COVID in these patients. A brief sidetrack to blood clots. I won't talk too much about blood clots, but venous thromboembolism or blood clots going to the lungs happened in about 25% of patients admitted to the ICU in the initial waves of COVID. And about 40% of those patients died. So this was a frequent thing in people who are really sick with COVID. And if you had this, it was very, very poor prognosis. And this is just one example here. This is a patient who has been given intravenous contrast. So their blood vessels are supposed to light up bright white. And you can see here this gray blob is this blood vessel that's basically blocking blood supply to the patient's right lung. And you can imagine that if you block blood supply to the right lung, especially if you're doing the same thing to the left lung at the same time, that has a really poor prognosis. This guy survived, and when we saw him 3 months later, his pulmonary artery still has an abnormal shape to it, but he was doing better, and his lung function was not normal, but for sure it was better than it would have been if we'd been able to measure it back here when he had his acute COVID episode. So the BC experience was an interesting one. And I haven't thought about this in too long, but when we saw that COVID was coming in early March, there were a few of us that got together and said, this is a respiratory disease, but we really have no idea what's going to happen to these patients. And we were pretty sure that we were going to face an onslaught of patients with COVID over the next few years. It was pretty clear at that point that it was not going to go away, and it was pretty expected that it would actually turn into exactly what it's become. And so at the very beginning of the pandemic, we set up a post-COVID respiratory clinic run at St. Paul's and Vancouver General Hospital. I was one of the ones at St. Paul's leading that, and then some partners at BGH leading the one over there. And we set up a process such that everybody admitted to hospital in Vancouver Coastal Health was automatically referred to our clinic. And we did that for wave one, and we were able to do that for wave one because BC wasn't overrun with COVID like other parts of the world, or like many other parts of the world were. So we were pretty good at seeing everybody admitted to hospital from wave one came to our clinic. during this catchment period that lasted for about 3 months before we had a little bit of a reprieve in the summer of 2020. We had a very strict or a very rigorous assessment process for these patients. So all of these patients underwent a pulmonary function test and a walk test. We also tested their respiratory muscle function, these MIPS and MEPS tests. We got a blood sample that included a whole bunch of the blood tests that I mentioned before, as well as a whole battery of other ones, as well as collecting samples for research purposes. Everybody got a CT scan, an echocardiogram, which is an ultrasound of the heart. They answered a bunch of questionnaires, which I'll go into in a sec, but looking at shortness of breath, cough, quality of life, depression, anxiety, sleep, and frailty. And then, as I mentioned, a research blood sample. And because we didn't know what to expect with these patients, we were doing this at 3 months, 6 months, 12 months, and 24 months. And we've now finished the 24-month visit for all of these patients. And we were fortunate to have learned a lot about this disease through setting this up. I'm going to show just 2 of the studies that we published early on back in 2020. We have a number of additional studies that are following these, and this cohort has migrated from just a respiratory clinic into a much more multidisciplinary clinic. And I'm happy to answer questions about that as well, but it's gone beyond just lung disease at this point. So the first study was looking at the respiratory outcomes at 3 months. And we really had 2 main questions that we wanted to answer with these studies. This is clinical research methodology kind of stuff over here, but really what we wanted to find out is how do we follow patients up? What tests are necessary after an acute COVID infection? And how do we determine who should be followed and who shouldn't be followed? Can we use things like the days that they spent on oxygen in hospital to inform who's going to have symptoms, who's going to have abnormal pulmonary function tests, and who's going to have an abnormal CT scan 3 months after the fact? Same kind of idea. Can we use shortness of breath at 3 months to identify who's going to have abnormal pulmonary function tests? So these answer different clinically relevant questions that family doctors and other specialists would be asking after patients get an acute COVID infection. Essentially, who should be followed up and who should have which tests done after the fact. So we saw about 80, I think it was 88 patients in the end from wave 1. And so this summarizes what those patients looked like at the time of admission to hospital. On average, 67 years old, predominance of men, BMI in kind of a usual sort of range. Just over a third had smoked in the past. Most people had presented to hospital with shortness of breath and cough. And they had these kinds of comorbidities, which I won't go through the details for the sake of time. They were fairly sick, so they spent an average of 10 days in hospital. The majority required oxygen. Majority of required oxygen for more than a week. 20% were on a ventilator, and again, obviously survived, but were on the ventilator for a long time. 8 days on a ventilator is not pleasant. And then these were their symptoms when they came to see us at 3 months. So 20% of patients still had shortness of breath 3 months after the fact. 20% had cough. Their walk test was relatively normal. Their CT scans, I'll go into this in a bit as well, but there were abnormalities on the CT scan. And their pulmonary function tests were close to normal on average, but with a lot of variability. The average DLCO, though, was 77% of normal. So another way of looking at this is that assuming people started off with relatively normal lung function, and none of these patients had lung disease prior to this, with I think 1 or 2 exceptions who had asthma, who had a normal pulmonary function test. So if you assume that people had normal lung function tests prior to this, then you would assume that the people who had COVID and came to our clinic had lost 20% of their lung function at this point. And you can imagine that losing 20% of your lung function is not a good thing. You can only do that a few times before you end up not being able to survive that. We looked at, again, abnormal DLCO. So DLCO was abnormal in 52% of people. So half of people had an abnormal pulmonary function test. mostly based on that DLCO being low. Interestingly, though, people were still short of breath even if they had normal pulmonary function tests. So shortness of breath and your pulmonary function test didn't seem to completely align with each other. The majority of patients, the vast majority of patients, had abnormal imaging at 3 months, and just over half had more than 10% of their lung affected by scarring on the CT scan. And that's a lot. That's the amount that I pay attention to as a subspecialist who deals with pulmonary fibrosis. This is the amount that you would definitely pay attention to in other diseases. So abnormal imaging was quite common. I won't go through the details of this other than to take home a few messages here. So messages from this table is that ongoing shortness of breath is really difficult to predict. It's not just related to your lung function or the severity of your acute illness. The days on oxygen during your acute hospitalization do predict the presence of abnormalities at 3 months. So the people who had sick acute illnesses have ongoing deficits at 3 months from a pulmonary perspective. And then shortness of breath at 3 months does correlate with your lung function, but imperfectly. We also had a second study that we published right around the same time looking at what patients were telling us. So different questionnaires, as I mentioned before: quality of life, frailty, shortness of breath, depression and anxiety, and then sleep. And we looked at this in patients who did not have and who did have previous comorbidities based on this Charlson Comorbidity Index. And what we saw from this is that it didn't really matter if you had previous comorbidities or not. A lot of people had abnormalities in these tests. So the whitish part of all of these are the abnormal parts. So the higher the score here, the more abnormal you have for these tests. And you can see about half of patients had abnormalities in these different domains. So symptom abnormalities was very common after COVID, and it didn't seem to matter whether you had previous comorbidities or not, which would suggest that a lot of these symptoms resulted from that COVID infection itself. If we look at the different domains, it's really the people who had comorbidities who had much more persistent anxiety. So having an underlying chronic disease predisposed you to having more anxiety after COVID. So that was what we saw at 3 months, and we've studied and published a few follow-up studies as well. But I wanted to end on a bit more of a good news front, and that really is to focus on vaccines and Omicron. And these data that I showed are all before we had vaccines. And we know that vaccines reduced mortality, at least in the clinical trials, by close to 95%. And they're probably not as effective at preventing mortality now, but they really were a game changer for the first strains of COVID. And again, all of our data are pre-vaccine. I would expect that vaccines would have improved things quite a bit if our first wave of patients had been fortunate enough to have a vaccine available to them at that time. The second good news part is Omicron. And I know Omicron has kind of run rampant through the world. But the good thing about Omicron is that it has run rampant because it targets more of the cells that are in the upper airway and doesn't target as well the cells that are in the lower airways. And it's really the lower airways that cause the problems. Upper airways, it's annoying. You'll have a runny nose, you'll have a sore throat and such. But you're much less likely to have COVID go into the lungs to the extent that it did with the first strains of everything up until the Delta strain. So Omicron, in a way, is a way of everybody getting some immunity with a much less risk of bad things happening. I think from a societal perspective, we would much rather have Omicron running around than still having Delta as the main strain that was out there. Having said that, there are some people who, for various reasons, don't do well with Omicron either. So I think it's obviously premature to say that everybody is out of the woods or that Omicron is a good thing for everyone. But it, in a way, is what we needed to get out of the pandemic, with the vaccines being imperfect and not being widely used in some populations, in some parts of the world at least. So I think those are the two good news parts, and hopefully this coming winter we'll have a much more normal winter than the last couple that we've had. So with that, I'll stop with a few conclusions and summary slides. So we talked about how do the lungs function, and again, lungs absorb oxygen through delicate structures, the alveoli, that can be affected by a variety of diseases. And we talked about the thickened interstitium for pulmonary fibrosis, and then airway and mucus kind of issues for other types of airways diseases like asthma, COPD, and cystic fibrosis. We talked about the different tests that we use to diagnose and monitor various lung diseases. We focus mostly on symptoms, pulmonary function tests, and chest imaging for the monitoring part, and then sometimes some others as well for diagnosis. And then in terms of how COVID-19 affects the lungs in the short and the long term, in the short term, 50% are asymptomatic, and maybe that's higher even now with vaccines and previous infections and with Omicron. Many patients do get respiratory symptoms and pneumonia. We see that much less often now, and there are relatively few people admitted to hospital now with COVID. In the long term, some patients will have permanent loss of lung function, especially those who are admitted to hospital with pneumonia who are quite unwell in that acute setting. And there are many other potential sequelae of COVID as well. It really is a multidisciplinary disease in the long term. And as I mentioned, there are some good news and hopefully a better year ahead for us than the two behind us.